Good morning, everyone. My topic for today's presentation is occipital lobe, its function, tests, and role in psychiatry. And my moderator is Dr. Sumit Mehta, sir. This is an overview of all of the topics that we will be going through today. First, we will talk about the anatomy of the occipital lobe, then the lesions of the occipital lobe, and finally, the diseases which affect the occipital lobe. Now, the anatomy of the occipital lobe can be divided into the supralateral surface of the cerebral hemisphere and the medial surface of the cerebral hemisphere. On the supralateral surface of the cerebral hemisphere, the occipital lobe shows rather three short sulci. One of these, which is the lateral occipital sulcus, it lies horizontally and divides the lobe into superior and inferior occipital gyri. The lunate sulcus runs downward and slightly forward, just in front of the occipital pole, and the transverse occipital sulcus is located in the uppermost part of the occipital lobe. The upper end of the parieto-occipital sulcus, which just reaches the supralateral surface from the medial surface, is surrounded by the arcus parieto-occipitalis. Now, on the medial surface of the cerebral hemisphere, the region between the parieto-occipital sulcus and calcarine sulcus is the cuneus, and below the calcarine sulcus is the lingual gyrus. Now, as we can see in this diagram, this is the superior occipital gyrus, and this is the lateral occipital sulcus, which divides it into the superior occipital gyrus and the inferior occipital gyrus. This is the arcus parieto-occipitalis. This is the supralateral surface of the cerebral hemisphere. So this is the lateral occipital. Okay, so this is the lateral occipital sulcus, which divides the occipital lobe into the superior occipital gyrus and the inferior occipital gyrus. And so this is the parieto-occipital sulcus here, and this is the arcus parieto-occipitalis. So this is the supralateral surface of the. Yes.
What is that sulcus? In all the sulcuses in supralateral, or you are concerned about one sulcus? Other sulcus?
So this is the lunate sulcus.
It's going to explain. And what about the sulcus below arcus parieto-occipitalis?
So this is the. So that is a supramarginal gyrus, so it is located in the parieto. This was
okay. Go ahead.
So this is the medial surface of the cerebral hemisphere. In this, the occipital lobe, this is the cuneus. So this is the calcarine sulcus. Here is the lingual gyrus. And so this is the parieto-occipital sulcus. So these are the Brodmann areas which are present in the occipital lobe. On the medial surface, there is the primary visual area, which is area 17, and visual association area, that is area 18 and 19 of Brodmann. This is supplied by the posterior cerebral artery. On the supralateral surface, along the superior occipital gyrus, we again have the visual association area, that is area number 8 of Brodmann, which is supplied by the posterior cerebral artery. And the inferior occipital gyrus, there is the visual association area, area 8 of Brodmann, supplied by the posterior cerebral artery. Around the occipital pole, there is a primary visual area for macular vision, which is area number 17 of Brodmann, and is supplied by both the middle cerebral artery and the posterior cerebral artery. Now in this diagram, we can see that along the occipital lobe, here is the primary visual area, and this is the visual association area. So the visual areas are area 17, 18, and 19. And sir, along the medial surface, here is the visual association area, and these are the primary visual areas. The visual areas, which are areas 17, 18, and 19 of Brodmann, they are located mainly on the medial surface of the occipital lobe, both above and below the calcarine sulcus. Now it will receive fibers of the optic radiation. The visual areas give off efferent fibers also, which reach various parts of the cerebral cortex in both hemispheres. In particular, the frontal eye field, which is concerned with the eye movements. Like other sensory areas, these visual areas, they also connect with functionally related motor areas. This is substantiated by the fact that movements of the eyeball and head can be produced by stimulation of areas 17 and 18, which constitutes the occipital eye field. The efferents from visual areas also reach the superior colliculus, the pretectal region, and the nuclei of cranial nerves supplying muscles that move the eyeballs. The lesion of this area will cause contralateral homonymous hemianopia with macular sparing in vascular regions, but there is no macular sparing in trauma or tumors. In the visual association area, which are area 18 and 19, they are responsible mainly for interpretation of visual impulses, which reach area 17, and they're often described as visual association area. The lesion causes visual agnosia, that is loss of ability to recognize objects, and word blindness, that is alexia. Lesions of the occipital lobe, they can be divided into mesial and lateral. If there is a mesial lesion of the occipital lobe, it can cause visual field defects, visual agnosia, visual hallucinations, alexia without agraphia, visual anosognosia, or antral syndrome, that is denial of blindness. If there is a lateral lesion of the occipital lobe, it can cause alexia with agraphia, impaired opticokinetic nystagmus, palinopsia, and visual alesthesia. First, we will talk about the visual field effects. Now, in the retina, we have nasal fibers and we have temporal fibers. The nasal fibers, they are responsible for the temporal vision, and the temporal fibers are responsible for the nasal vision. Then along this, we have the optic nerve. This is the optic chiasma. These are the optic tracts. Here we have the lateral geniculate body. And finally, we have the optic radiations and the primary visual cortex over here. The lesion of the optic nerve, it will cause complete blindness in the part of the eye which is damaged, of the optic nerve which is damaged. And if there is a damage in the optic chiasma, since in the optic chiasma, the nasal fibers, they decussate. The nasal fibers are one portion, as we can see in this diagram. The nasal fibers, they are decussating over to the opposite side. And hence, the lesion of the optic chiasma, it will cause bitemporal hemianopia. In the now any post-chiasmal lesion, that is lesion which affects the optic tract, the lateral geniculate body of the optic radiation, that can cause homonymous hemianopia. Now in this here, sir, in the if the injury to the optic radiation, it occurs along the parietal lobe, it will cause inferior quadrantopia, and if the lesion it occurs in the temporal lobe, it will cause superior quadrantopia. And so finally, if there is damage to the primary visual area, it causes a homonymous hemianopia with macular sparing. As in vascular lesions, it is mainly macula is supplied both by the posterior cerebral artery and the middle cerebral artery. Sir, hemianopia is defect in one field of vision. Yes, sir. Yes, sir. Yes, sir. Half field of vision is affected. Sir, in homonymous, the field effect will be in same half of the visual field. Same side. That side of visual field will be. Okay, the right side lesion is there, then the person will not be able to see right field of vision. Okay. Sir, in the yes, sir. So this is the recording. So the recording stop.
Yes, we will know it by temporal. By
Yes.
temporal hemianopia.
So in bitemporal, so because here the nasal fibers, so as we can see in this diagram, the right side, so the nasal fibers, they are moving to the opposite side. And sir, on the left also, so the nasal fibers, they are decussating to the opposite, so the nasal fibers are affected. Sir, so in both the fields of vision, they will be by, so the temporal field of vision. So the patient, he will not be able to see the
patient का तो vision कैसा हो? Temporal को गया, vision कैसा हो?
Sir,
आपने बताया nasal से उधर को जाता है, nasal से temporal जाता है.
So only central field also, peripheral field, central field, peripheral field.
कैसे होता है?
Pituitary gland.
उसमें हम लोग सीधा हमारा लिखने से पहले फील्ड आपको चार्टिंग करनी तो उससे आपको पता चल जाता है एटलीस्ट क्लिनिकली डाउट that is because the size of the head is not correlating with the lesion. So size of the guidance for whether you go for operation or not. If it is pressing upon, like if it is minimal, okay, then it is an indication for surgical intervention. Yes.
Now we talk about visual agnosia. Visual agnosia is a rare acquired neurological syndrome in which patient is unable to recognize objects or pictures of objects which are presented visually. In this, the visual acuity is adequate, mentation is clear, and aphasia is absent. There are two types of visual agnosia. In the first type, actual visual perception of the object is distorted to the point that recognition is impossible. Now, such patients cannot name or tell the use of an object when it is shown to them, but can readily name and demonstrate the use of object when it is placed in their hands. It has been postulated that such patients have damage to the visual association cortex bilaterally. Now, this type of visual agnosia, which is called as aperceptive visual agnosia. Now, this has been reported in a patient with anoxic encephalopathy secondary to carbon dioxide poisoning and in patients with Alzheimer's disease. The second variety of visual agnosia is called as associative visual agnosia. Patients with this type of agnosia, they have adequate visual perception, but here the visual cortex is completely disconnected from the language area or the visual memory stores. Accordingly, they can recognize the object, they can demonstrate its use, but they cannot name it. And when they are unable to name an object, they are also unable to describe its use. Lesions that cause an associative visual agnosia, they may be bilateral, involving the inferior temporal occipital junction and subadjacent white matter, or they may be an infarct that completely destroys the left occipital lobe and the posterior corpus callosum. This is the same lesion that causes alexia without agraphia, and in fact, most patients with associative visual agnosia, they're also alexic. Now, how do we test for visual agnosia? To evaluate for the presence of visual agnosia, we ask the patient to identify verbally common objects which are presented visually to the patient. If the patient fails to recognize the object, we allow manipulation of the object. Now, if the patient then readily identifies the object, the defect is in the visual system. The evaluation for associative visual agnosia is similar to that for the first type of visual agnosia, except that adequate visual perception must be demonstrated. Now, lesions of occipital lobe may also cause visual hallucinations. Simple visual hallucinations consisting of flashes of light or photopsias or lines of different colors that adopt similar patterns, that is zigzag, circle, or fortification pattern, often accompany a defective field of vision and indicate inferomedial occipital disease, usually migraine or an epileptogenic lesion. The elementary visual hallucinations with occipital epileptic seizures are predominantly multicolored, with circular or spherical patterns as opposed to the predominantly black and white zigzag linear patterns of migraine. Unformed visual hallucinations in one hemifield, which are probably ictal in nature, seen only with vigorous exercise, have been described in patients with occipital brain tumors and may be a specific symptom of occipital tumor. In alexia, the classical syndrome of pure alexia without agraphia is caused by a left posterior cerebral artery occlusion in a right-handed individual. The resulting cerebral infarct damages the posterior portion of the corpus callosum as well as the left occipital lobe. So in alexia, the patient, he will not be able to understand the reading or the letters which are written.
The word.
So word blindness. So this is the inability to understand to written letters. So recognize or read written letters.
Word blindness.
Because the left visual cortex is damaged, all visual information enters only the right hemisphere, and the right visual cortex perceives the written material but cannot transmit it to the left hemisphere because of the callosal lesion. In Anton syndrome, patients with acute bilateral and extensive medial occipital lesions that render them blind may deny having any difficulty with seeing, that visual anosognosia, and they confabulate about what they see. Such a phenomena often appears in the setting of a generalized metabolic encephalopathy. When related to discrete lesions, these are likely to extend beyond the calcarine cortex to include visual association cortices. So in this, the patient, they have extensive medial occipital lesions, and because of this, they cannot see. But the patient, he will deny that he has any difficulty in seeing, and he will lie about what he's seeing.
Why will you deny? Basically, patient is not able to see. The patient will not report that I'm not able to see or I'm blind, and would actually. So what he's actually seeing is confabulated. The cortical blindness is something like that. Because of some part of actually and that's why you basically, visually he's seeing, but he's not interpreting the information because the interpreting area is burned out. Extensive lesions, because of extensive lesions, because medial occipital lobe has this primary visual pathway and association cortices. So that is why, so blind sight. So I think better term would be patient is actually not perceiving. Patient is having intact senses. Patient uske perceive nahi kar pa raha hai, visual. The patient will never report it. At times it is difficult to diagnose it. See, not be able to see anything, but you will be able to see there is moving and there is a big object in front of you. So probably you will be able to see that. Then yes, it is one of the deny it.
In alexia with agraphia, in addition to the reading and writing disturbance, these patients usually have acalculia, finger agnosia, right-left disorientation, and difficulty with spelling words and understanding spelled out words. A pure angular gyrus lesion is most likely if the patient does not have a Wernicke's aphasia. Many patients having alexia with agraphia have a partial or complete Gerstmann syndrome. Sir, in agraphia, it is inability to write letters, symbols. Yes.
So in occipital lobe, they will not have indirect right.
Sir,
these you are seeing in occipital lobe along with that distance.
yes, sir. Palinopsia. In palinopsia, the image will recur immediately after diverting the gaze or when the stimulus object is withdrawn. The image is frequently achromatic, may be revived by blinking, is not affected by eye closure, and moves in the direction of eye movements, and rarely it moves opposite to eye movements. These illusory phenomena, they occur on the same side as an impaired but not blind visual field, and are associated with occipitotemporal disease. Also, palinopsia may occur during recovery from cortical blindness in the recovering portion of the visual field. Most cases of palinopsia occur with focal, non-dominant parieto-occipital or occipitotemporal lesions, although rarely posterior left hemisphere or more anteriorly placed pathology may cause this defect. Now, prosopagnosia. Prosopagnosia is an unusual agnosia in which patients are unable to recognize familiar faces. In such cases, the agnosia is so profound that even members of the patient's immediate family are not recognized. The patient will recognize the person, however, on hearing his or her voice. The mechanism that results in prosopagnosia is probably a combination of a disturbance of fine visual discrimination and a failure of memory for the discrete category of human faces. The lesions that are responsible for this disorder are usually in the occipitotemporal areas bilateral. One of the lesions is usually in the right inferior temporo-occipital region. The color agnosia. Color agnosia is an inability to recognize colors secondary to an acquired cortical lesion. Two types of color agnosia have been described. A specific color naming disturbance, which results from a disconnection of visual input from the language area. This anomia is usually associated with the syndrome of alexia with agraphia. In this form, there is no damage to the primary language area and no other evidence of aphasia. The second and more common disturbance of color recognition is usually a defect in color perception caused by bilateral inferior temporo-occipital lesions. These are the same lesions that cause prosopagnosia, and most patients with this type of color agnosia have concomitant prosopagnosia. Visual inattention. Unilateral visual inattention refers to the phenomena found in some patients with parieto-occipital lesions. No field effect is found on unilateral testing. But when stimuli are placed on both right and left hemifields, the patient appears not to see the object on the field opposite to the lesion. Unilateral visual inattention is often seen with incomplete homonymous defects and in the process of recovery of a dense field defect, particularly at the margins of the defect. Now, landmark agnosia. These patients have difficulty finding their way around because their ability to recognize familiar landmarks is impaired, and most of these patients have right temporo-occipital lesions. In assessment of the occipital lobe, now since occipital lobe is not a part of higher mental functions, its examination is primarily done by anatomical correlations of lesions of visual tracts. Now, occipital lobe role in psychiatry. Now, first we will talk about occipital lobe epilepsy. Occipital lobe epilepsies manifest with occipital seizures from an epileptic focus within the occipital lobes. Ictal clinical symptoms are mainly visual and oculomotor. Elementary visual hallucinations are common and characteristic, and post-ictal headache occurs in more than half of the patients. The ictal clinical manifestations of occipital lobe seizures. Visual subjective symptoms include elementary and less often complex visual hallucinations, blindness, visual illusions, and palinopsia. Then there can be ocular subjective symptoms comprised of ocular pain, and objective oculomotor symptoms include tonic deviation of the eyes and repetitive eyelid closures or eyelid fluttering. The tonic deviation of the eyes often, but not necessarily, is followed by ipsilateral turning of the head, and this is the most common non-visual symptom of occipital seizures. Repetitive eyelid closures, eyelid fluttering, and eyelid blinking usually occurs after the visual hallucinations phase, at a stage when consciousness is impaired and herald the impending secondarily generalized convergence. Ictal headache, mainly orbital, is frequently associated with occipital seizures. In the management of occipital seizures, the anti-epileptic drug treatment is similar to that for any other type of focal seizures, is usually effective and should be initiated as soon as possible. Recommended anti-epileptic drugs for monotherapy include carbamazepine, lamotrigine, levetiracetam, oxcarbazepine, and topiramate. And sodium valproate, it can be useful in some patients with idiopathic photosensitive occipital epilepsies in children. On a postcoital headache, which is characterized by headache immediately after coitus, may last for several hours, and it is usually described as throbbing and is localized in the occipital or frontal area. The cause is unknown, and they may be vascular, muscle contraction, or psychogenic causes. In conduct disorder, now a study, it investigated structural brain differences in children comorbid for oppositional defiant disorder or conduct disorder and ADHD compared to those with ADHD alone and normal controls. And the findings included decreased gray matter in ADHD and ADHD comorbid for oppositional defiant disorder or conduct disorder compared to controls and regions, including bilateral, temporal, and occipital cortices and the left amygdala. These are my references.
Sensory part of the not play any part in motor.
Yes, so there are connections which are present to the fibers.
Different fibers. So they can control they relate to the motor part. So like you're focusing on an object or a person, like you say the object, that also the key parts level. So the information is there related to something. So control of them. Unless you don't that is going to make that motor part of the tripod. I think the situation of visual with the motor part. We can fix on like a ball object. So that requires
So I mentioned it in the starting, the anatomy portion of the occipital.
Did you come up with this term by today? Explain.
The patient is able to appreciate.
This is testing of simultaneously. How the patient is present with simultaneously. When you test, this is the way to test it, but what is the term implies? You're right, that is good. But what the term implies and how the patient is present in the just in daily basis to get this problem. As a whole, yes, and part of the thing. Simultaneously, मतलब पूरी complete picture नहीं वो कैसे कर देगा बस part हमने यहाँ पे देख रहे हैं और यहाँ पे देख तो वो तो मेरा भी फोकस कर पा रहे आज तो समझ नहीं आ रही कि आप लोग बैठे हो बैठे हैं क्लास में इसका अपोजिट भी होता है कि होल कर लेता है और पार्ट नहीं करता मल्टीपल एक्सप्लोर भी करता है साइमल्टेनियस करना साइमल्टेनियस वर्ड पूरे इकट्ठे तो इसको साइमल्टेनियस पूरा फील कर रहे पार्ट पार्ट that's the only comment we further simultaneously. Okay. There's also balance drop. What are you doing? Condition. This is another classical effect about on-road state. On-road state पूछते हैं हमारे जमीन के level of consciousness is less. Allowing this schizophrenia is less than or altered consciousness. Schizophrenia without any and then like state on the that's the name is
Balancing is caused either by bilateral or unilateral region in the posterior protective and occipital cortex. And apart from this, the occipital lobe epilepsy, the seizures, they are mostly triggered by flash of or visual image, and these are known as flicker stimulations. So these are mostly seen during the day when, like for example, watching the TV, and they usually originate from an epileptic focus that is present within the occipital lobes, but the exact etiology.
what does that in the sport?
Flip. Focus and stimulus.
So yeah, time to see news, they will, if there is flash photography, there is without the government that so get photo stimulation from that. So even in some like BBC, they will put out that this episode may have that. somebody is going to see the any celebrities, there's a lot of that. If you want to upfront that. But that season can absolutely.
So, how do you? And beyond that, I always give such things are better explained in I
Although it is one of the less different topics in terms of near nothing, it was not the group of other good presentation. I joined the late. So you should, whenever you are presenting, always, if you don't put it in a slide, at least tell what you imagine. Because when you are preparing a slide, many of the terms by reading it for coming to be accustomed to that, to what it actually means. But for somebody who's coming up there, like your colleagues, so you should always explain the terms. What is it? One line. Alexia means word by blindness. Okay. Yeah, no, normal term, just explain. So it is easier for the audience to follow. And so, the second thing I told you last time. So if you take figures, just put a reference in that figure video. Okay. If you're putting it on YouTube, somebody can copyright that. So it's now. So one must put the source and to take an image, just like if not proper reference, just from the book reference. If somebody wants to see and understand it better.